Hello everybody, thank you for dropping by my channel and watching and listening to this video. In this video today I'm going to summarize the most latest issue of the TOG journal, which is the April 2022 version for the MRCOG Part 2 exam. Now then, so when I revised for my exam, I always somehow left the TOG articles as the last thing I'd read on my revision day. So, for example, I'd look at the guidelines, I'd try and do questions, and then come to the TOG articles. The problem with that was I'd always not be able to focus and pay as much attention as I should have. And what I had realised was that the TOG article information was quite important, piece of information for the exams. So what I started doing was creating these summary slides to help myself fish out the most important points, but also help me remember and retain this information as much as I can. So what I'm doing now is I'm going to summarize and share these slides with you with an audio to it as well, so you can listen to it in any free time, such as commuting to work or out for your evening run and so forth. So in this article, so in this particular summary, we've got 6 articles. What I've done is included the most important points, including the green boxes, the flow charts, the flow diagrams from all these journals. I hope you'll find this presentation really useful and you'll be able to benefit from it as much as I did during my revision. Okay, so this is a TOG April 2022, the most latest version of TOGs that's out there on the RCOG website, and I've summarized this for you. It's got 6 articles in it, and we can start with the first one. Okay, so the first one is titled as Impact of the Intrauterine Environment on Future Reproductive and Metabolic Health. The key content is what I'm going to read out now, and the learning objectives, so you can see for yourself whether you're covering them when you are revising from the summary slides. So the key content: as survival of babies born following high-risk pregnancies continues to increase globally, understanding the long-term impacts of suboptimal intrauterine environments on future health becomes increasingly important. The intrauterine environment is a key influence on later metabolic health, particularly the tendency to later life obesity and dyslipidemia. Recent evidence shows that female reproductive function is also highly sensitive to the influence of the early life environment. Various suboptimal intrauterine environments are linked to adverse reproductive and metabolic outcomes, including maternal obesity, low protein diets, and chronic fetal hypoxia. Learning objectives: to know that the prevalence of high-risk intrauterine environments is increasing in maternity populations because of, for example, increasing rates of maternal obesity. To be aware of the later life health implications for the fetus when caring for women with high-risk pregnancies. To understand that children who are survivors of high-risk pregnancies are at increased risk of adverse metabolic health outcomes, and more work is required to determine optimal follow-up. So in the UK, 50% of women of reproductive age are overweight or obese. 1 in 5 are obese during the pregnancy. 1 in 20 are diagnosed with GTM. 1 in 10 is a smoker during pregnancy. Okay, so now this diagram of how these suboptimal early life environment has an impact on the fetus. So things like maternal obesity, gestational diabetes, maternal age, smoking, chronic fetal hypoxia all lead to accelerated cellular senescence, HPA axis dysregulation, epigenetic changes, altered tissue and organ structure, which then later in life impacts and causes obesity, diabetes, cardiovascular disease, dyslipidemia, polycystic ovarian syndrome, decreased ovarian reserves, and pubertal timing. So it's suboptimal environment that causes developmental programming changes within that, which then leads to adverse metabolic and reproductive outcomes. The next table then shows how potential developmental programming factors and suggested management. So the maternal factors like low body mass index and being underweight, for example, um, leads to obesity and hypertension later in the offspring's life. The management for this is correction of any nutrient deficiencies, advice regarding healthy weight maintenance, sensitive exploration of any related disorders like mental health issues. The next thing, maternal factor, is obesity. Leads to obesity in the future for the child, dyslipidemia, cardiovascular disease, and type 2 diabetes. So the way you manage that in the current pregnancy is by weight loss and dietary optimization prior to conception. Encourage physical activity and aspirin during pregnancy. The third maternal factor is smoking. Causes obesity, hypertension, and insulin resistance for the future. And the way to manage is by smoking cessation and aspirin use during the pregnancy. The fourth maternal factor is chronic fetal hypoxia, which again leads to obesity, cardiovascular disease, and the way to manage that is close monitoring of the pregnancy, including uterine artery Dopplers and optimizing timing of delivery. The fifth factor is gestational diabetes mellitus, GDM for short, leads to obesity, impaired glucose tolerance, and type 2 diabetes. And the way to manage that is to control diabetes in pregnancy, whether it's diet or lifestyle, metformin or insulin, advice regarding continuing maternal diabetes screening. So it's quite a nice little green table which shows you the factors and how that influences in the offspring's health for the future, and then how to manage it in the current pregnancy. Okay, so now we move on swiftly to our second TOG article, which is titled as Opioid Misuse in the Pregnancy. The key content for this article is the UK has one of the highest rates of opioid misuse in Europe, with dramatic escalation over the last decade. Much of this drug use in women coincides with childbearing age and continues into the pregnancy. Opioid misuse in pregnancy is associated with considerable obstetric and neonatal complications. Management of women with opioid misuse in pregnancy requires an MDT approach with specialist input from drug services. Opioid substitution regimes with methadone or buprenorphine during pregnancy have been shown to improve perinatal outcomes and the women's compliance with care. Learning objectives: to be familiar with the obstetric and neonatal complications that can arise from opioid misuse in pregnancy, in particular neonatal abstinence syndrome, to understand how opioid substitution regimes with methadone or buprenorphine can lead to an improvement in pregnancy and infant outcome. So opioids are central nervous system depressants, and they have analgesic effects. Now, antenatally, patients who have been using opioids should be in a consultant-led clinic. They should be offered routine screening for HIV, hepatitis B, and syphilis. Hepatitis C screening and testing should be offered to anybody who is currently or has any history of intravenous opioid use or is sex worker, and sexual health screening should also be offered to these patients. Urine toxicology for anybody who is current or previous drug user, or for anybody who has pregnancy in the pregnancy is using the opioids. Internationally and with UK guidelines, the recommendation is to continue using the drug until a suitable opioid substitution program has been advised for conversion is implemented for that patient. It's also important to do a fetal cardiac scan for women who are using SSRIs in the first trimester because they can increase risk of congenital malformation. It's important that at 32 weeks an MDT meeting is carried out to highlight any safeguarding concerns or reviewing the methadone programs and also to plan for delivery and postpartum how these patients would be managed. So intrapartum, these patients can have quite challenging venous access, so because of scarring and sclerosed veins. So it's important to consider early cannulation if that's required. The cesarean section should only be performed for obstetric reasons. Methadone or buprenorphine should be continued as normal during labour and should not be the only thing that's offered to them for pain relief. So other pain relief options during labour should still be offered. Continuous CTG monitoring should be offered to these patients because of risk of intrapartum hypoxia, fetal compromise and meconium owing to placental insufficiency because secondary to the drug use. Pediatricians is not routinely required at birth. However, if there is need, then one should be called. So, postpartum, opioid-dependent women require more analgesia post-delivery. Medications like oxycodone that can trigger relapse should be avoided. Because of changes in circulating volume postpartum, it can lead to either over-sedation from methadone in some patients, while in others, because hemodilution, they can lead to symptoms of withdrawal. Babies should be monitored for at least 72 hours following birth. Long-acting reversible contraception such as the implant and the coil should be offered to these patients before they're discharged from the hospital. Firstly, because they have the failure rates are less than 1%, and also it increases chances of compliance. And a safeguarding risk assessment should be done for these women before discharging them from the hospital. Okay, so now we've got some green boxes to go through. Maternal and fetal complications associated with opioid use in pregnancy, premature rupture of membrane / premature labour and delivery, fetal growth restriction, fetal death, low birth weight, respiratory distress syndrome, neonatal abstinence syndrome, neonatal mortality, sudden infant death syndrome, and neurocognitive abnormalities. Now, the DSM criteria for opioid use disorder. Opioids are often taken in large amounts or over a longer period of time than was intended. Persistent desire or unsuccessful efforts to cut down or control opioid use. A great deal of time is spent in activities necessary to obtain the opioid, use the opioid or recover from its effects. Craving or a strong desire to use opioids. Recurrent opioid use resulting in a failure to fulfill major role obligations at work, school or home. Continued opioid use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of opioids. Important social, occupational or recreational activities are reduced or given up because of opioid use. Recurrent opioid use in situations in which it is physically hazardous. Continued opioid use despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have being caused or exacerbated by the substance. Tolerance as defined by either of the following: a need for markedly increased amounts of opioids to achieve intoxication or the desired effect, a markedly diminished effect with continuous use of the same amount of an opioid, withdrawal as manifested by either of the following: the characteristic opioid withdrawal syndrome. Opioids are taken to relieve or avoid withdrawal symptoms. So this box highlights the criteria for an opioid use disorder. So how would you define that in a patient? So the next green box that I thought was useful and important in this article is physical and psychological and lifestyle issues encountered and suggested management strategies. So physical, the problem can be nausea and vomiting, common in early pregnancy and can lead to problems with taking methadone. Suggested management is antiemetics like so avoid cyclizine with methadone use owing to psychoactive effects. Splitting methadone into two smaller doses may overcome this. The second physical effect is dental infections, so common with opioid use, exacerbated by the acidity of methadone. Encourage women to attend for regular dental checkups. The third physical problem is issues relating to intravenous drug use. IV drug use increases the women's risk of bloodborne viruses, thromboembolism, and organ disease. So, offer screening for hepatitis C in addition to routine screening, plus or minus sexual health screening if at risk of other sexually transmitted infections. Provide details of needle exchange programs to avoid needle sharing and lower risk of bloodborne infections. Provide information on signs and symptoms of deep vein thrombosis, pulmonary embolism in pregnancy. Maternal echo to rule out any cardiac disease, example endocarditis. Psychological problem is mental health. 40% will have concurrent mental health issues. Referral to perinatal mental health services for the mother and infant mental health services. Offer treatment with improving access to psychological therapies or medication if necessary. Cardiac scan should be done for women on selective serotonin reuptake inhibitors, so the SSRIs, in the first trimester. Neonatal alert for women on medications can exacerbate neonatal abstinence syndrome with concurrent opioid use. Lifestyle problems, so domestic violence, high risk of domestic violence, especially if partner also drug user. The opportunity to be seen without partner present, referral to independent domestic violence advisor if necessary, midwife to complete relevant safeguarding alerts. The next lifestyle factor is smoking, higher rate of concurrent smoking, referral to stop smoking services, offer treatment with nicotine replacement therapy. The next lifestyle factor is financial and accommodation. Drug use often associated with socioeconomic deprivation and chaotic lifestyle. Financial hardship owing to need or to fund drug habit and unemployment. So involvement of a social worker, provide information regarding financial help available, example, employment and support allowance, access to work schemes, etc. So, the withdrawal syndrome is characterized by CNS irritability, gastrointestinal dysfunction, and autonomic hyperactivity. Symptoms usually appear 24 to 72 hours after birth in around 75% of babies. Mild symptoms are things like tremors and irritability to severe like fever, weight loss, and seizures. So features of neonatal abstinence syndrome. So in the respiratory system, you can have respiratory distress. In the central nervous system, you can have increased tone, high-pitched crying, sleep disturbance, tremors, irritability, seizures. In the gastrointestinal system, you can have poor feeding, vomiting, regurgitation, diarrhea, weight loss, excessive suckling. Autonomic, you can have fever, yawning, sneezing, sweating, mottling, and tachypnea. Okay, so this leads us on to the third article, which is the management of hemoglobinopathies in pregnancy and childbirth. Key content for this article is the hemoglobinopathies encompass a complex collection of red blood cell disorders that are responsible for considerable morbidity and mortality in women and their unborn children. Sickle cell disease and thalassemias are the commonest hemoglobinopathies encountered in the UK clinical practice. A consistent standard of care will enable women with hemoglobinopathies to have a pregnancy that is as safe as possible, with good outcomes and minimal long-term effects on their health and the health of the babies. The most effective way to deliver a consistent standard of care for these women is via the MDT team. The MDT should include a hematologist, a cardiologist, maternal medicine obstetrician, specialist midwife, reproductive medicine specialist, and a nurse specialist. The care of these women within the MDT should start with preconception advice and continue through antenatal care, interpartum support, and finally provide postnatal considerations, including contraception advice. Learning objectives: to understand the inheritance, incidence, detection, and pathophysiology of the commonest hemoglobinopathies, to appreciate the role of preconception advice and prenatal diagnosis in the management of women with a hemoglobinopathy, to appreciate the MDT team approach in managing women with these conditions. Okay, so the article then goes on to say that sickle cell disease and beta thalassemia major is an autosomal recessive condition. So for sickle cell disease in the UK, there's between 100 and 200 pregnancies per year. The common clinical manifestations of sickle cell disease include painful crises, avascular necrosis, stroke, pulmonary hypertension, retinal disease, leg ulcers, acute chest syndrome, renal dysfunction, and cholelithiasis. A summary of the common clinical manifestations of thalassemia include anemia of varying severity, skeletal deformities, osteoporosis, organomegaly, hypercoagulable state, iron overload, transfusion-related iron overload complications including hepatic, cardiac, and endocrine dysfunction. This then goes on to another green box which includes preconception screening in sickle cell disease. So, patient who's thinking about a pregnancy and has got sickle cell disease should have all these, tests done. This is also covered in the Green Talk guideline on the sickle cell disease. So, the tests include echocardiography. Indication is screening for pulmonary hypertension, and timing is within 1 year. Blood pressure and urinalysis, screening for hypertension and or proteinuria preconceptionally. Renal function tests to identify sickle nephropathy annually. Liver function test to assess for deranged hepatic function annually. Retinal screening for proliferative retinopathy, especially HBsC patients preconceptionally. T2 cardiac magnetic resonance imaging, screening for iron overload if history of multiple transfusions or identified high ferritin levels, again preconceptionally. Screening for red blood cell antibodies. Red blood cell antibodies may indicate an increased risk of fetal anemia and or hemolytic disease of the newborn, again done preconceptionally. Okay, so vaccines advised in patients with sickle cell disease and those with thalassemia who have undergone splenectomy. So pneumococcal vaccine, hepatitis B, H influenza type B, influenza and swine flu, conjugated meningococcal C, meningitis B, and ACWY. Sickle-related complications in the pregnancy. So the complications are anemia, pregnancy-induced. So in the pregnancy, it can cause pregnancy-induced hypertensive disease, and in the fetus, it can lead to miscarriage. So the next one is blood transfusion for pregnancy-related or exacerbated renal insufficiency, and for the fetus, it can lead to preterm delivery. Painful crisis, venous thromboembolism for the pregnancy, stillbirth for the fetus. Critical care unit admission, antepartum hospital admission, and can lead to fetal growth restriction. Acute chest syndrome can lead to postpartum infection, and urinary tract infections can also be exacerbated with sickle cell disease. Preconception issues in thalassemia, and summary of organ-specific issues with interventions, tests, reviews, and recommended by the RCOG, including targets where appropriate. So for thalassemia patients, for the heart, iron overload, so T2 cardiac magnetic resonance imaging, MRI is recommended. Its considerations is aim for a cardiac T2 of greater than 20 ms to reflect minimal iron in the heart. The risk of cardiac failure increases with a T2 less than 10 ms. Heart function, echocardiogram, and an ECG. Cardiology review to assess severity of any cardiomyopathy. A reduced ejection fracture is a relative contraindication to pregnancy requiring obstetric and cardiac MDT input. Liver iron burden. Ferry scan or liver T2 scan to assess for liver iron concentration. A target liver iron of less than 7 milligrams per gram is recommended to reduce the risk of myocardial iron loading. This risk increases if levels are greater than 15 milligrams per gram before conception. Liver infection and cirrhosis. Ultrasound should be used to identify cholelithiasis and liver cirrhosis. Hepatitis C virus, RNA positive women, those with cirrhosis should have a hepatology review. Liver cirrhosis can be caused by both iron overload and transfusion-related viral hepatitis. Both liver cirrhosis and active hepatitis C may run a more complex course during pregnancy. Cholelithiasis is common owing to hemolytic anemia. Pancreas, managing diabetic women or those who develop gestational diabetes with diabetes specialist MDT. Diabetes is common and good glycemic control is essential pre-pregnancy to reduce risk of congenital abnormalities. Aim for a fructosamine level of less than 300 nanomoles per liter. Thyroid function tests should be assessed. Untreated hypothyroidism can result in maternal and fetal morbidity, and so women should be euthyroid pre-pregnancy. Bone density, all women should be offered a bone density scan to document pre-existing osteoporosis. Vitamin D supplements should be offered where necessary. Vitamin D deficiency and osteoporosis are common. Red cell antibodies measure the antibody levels, full blood count, full blood group genotype, and antibody titers. Alloimmunity occurs in 11.4% of individuals with thalassemia. Red cell antibodies increase risk of hemolytic disease of the fetus and newborn. There may also be challenges in obtaining suitable blood in a timely manner for transfusion. Okay, so really love this diagram that is shown on your screens at the minute now with sickle cell disease, and it goes through the same thing with thalassemia. So it says, with sickle cell disease, antenatal appointments should provide routine antenatal care as well as disease-specific care. BP and urinalysis should be performed at each consultation, midstream sent for culture monthly. So, midwife booking and early MDT, 7 to 9 weeks, ultrasound for viability and presence of multiple pregnancies should be checked. 11 to 14 weeks, ultrasound for dating. 16 weeks, midwife and MDT should be seeing the patient. 20 weeks, an ultrasound for anomaly and MDT, MDT discussion again. 24 weeks, an ultrasound for growth and MDT. 26 weeks, the patient should be seen by the midwife alone. At 28 weeks, an ultrasound for growth and MDT again. At 30 weeks, the patient should be seen by midwife again. At 32 weeks, an ultrasound for growth and MDT. 34 weeks, a midwife again. 36 weeks, an ultrasound for growth and MDT. 38 weeks, again seen by the midwife. 39 weeks again seen by the midwives, 40 weeks advised delivery, and you should really offer them delivery from 38 weeks onwards. So basically, from 20-week onwards, you're seeing the patient every 4 weeks in the antenatal clinic for a growth scan and multidisciplinary team approach to their care, and they're being seen in between every 2 weeks by the from 24 weeks by the midwives, so at 26, 30, 34, and 38 and 39 weeks. Okay, so for thalassemia patients, there's a similar diagram. Again, it says the same thing about antenatal appointments, should provide routine antenatal care as well as disease-specific care. BP and urinalysis should be performed at each consultation and a midstream sent for urine for culture monthly. So, midwifery booking, 7 to 9 weeks, again, ultrasound viability and presence of multiple pregnancies should be checked. 11 to 14 weeks, an ultrasound should be done for dating. 16 weeks, a midwife appointment and MDT. 20 weeks, an ultrasound for anomaly and MDT. 24 weeks, an ultrasound for growth and MDT. 28 weeks, an ultrasound for growth, MDT, including cardiology review and plan. 30 weeks, midwife should see the patient. 32 weeks, an ultrasound for growth and MDT again. 34 weeks, a midwife should see the patient. 36 weeks, an ultrasound for growth and MDT plus or minus cardiology input. 38 weeks, a midwife should see the patient. Again, at 39 weeks, the midwife should see the patient. 40 weeks, MDT. 41 plus weeks offer delivery. So really, the difference between sickle cell disease and thalassemia, according to this diagram in terms of management, is at 28 weeks, you're definitely involving the cardiologist, and at 36 weeks is plus or minus cardiology input. But in terms of scanning, you're scanning them every 4 weeks again, just like your sickle cell patients at 20 weeks, 24 weeks, 28 weeks, 32 weeks, 36 weeks. You're scanning these patients, seeing them in antenatal care, managing the condition, along with seeing the midwife in between every 2 weeks, and offering delivery from 41 plus weeks. Whereas for sickle cell disease, you offer delivery from 38 weeks, and at 40 weeks, delivery was advised. Okay, so the next green box is a summary of acute presentations in women with sickle cell disease. So it goes through the complications, presentation and diagnosis, and the initial treatment. So acute chest syndrome, characterized by respiratory symptoms like shortness of breath, tachypnea, chest pain, and cough, with an associated new infiltrate on the chest X-ray. Management is intravenous antibiotics and oxygen. Blood transfusion in acutely sick and top-up blood transfusions may be required if hemoglobin levels are falling or already less than 65 grams per litre. However, in severe hypoxia, where the hemoglobin levels are maintained, exchange transfusion will be necessary. The next complication the next common presentation is stroke, both ischemic and hemorrhagic. Acute neurological impairment requires urgent brain imaging to diagnose and differentiate the type of stroke, as this will influence timely treatment options. Management is immediate hematology review for consideration of urgent exchange transfusions to reduce long-term neurological damage. Thrombolysis should be considered in acute stroke secondary to sickle cell disease. The next complication is Erythrovisious infection, which is parvovirus B19. Infection triggers an aplastic crisis. Investigations demonstrate an acute anemia with reticulocytopenia owing to red cell maturation arrest. Treatment is blood transfusion, isolation of women, fetal medicine review owing to risk of vertical transmission, and fetal anemia leading to hydrops fetalis. Okay, this now gets us onto the fourth article for the day, which is diagnosis and management of fetal cardiac arrhythmias. So key content is fetal cardiac arrhythmias are relatively common and account for up to 20% of referrals to fetal cardiologist. Arrhythmias may occur because of structural abnormalities of the fetal heart or because of abnormal functioning of the cardiac conduction system in an otherwise structurally normal heart. Arrhythmias may be diagnosed using ultrasound and M-mode and Doppler echocardiography. Transplacental therapy for tachyarrhythmias has been one of the success stories of fetal cardiology, and good outcomes can be expected in the absence of eye drops. Congenital heart block is most commonly is most commonly caused by transplacental passage of anti-Rho and anti-La antibodies, and transplacental therapy is less successful in managing this. Learning objectives: to enable clinicians to provide better counseling for patients about the prognosis of fetal arrhythmias, to learn how to diagnose fetal arrhythmias and know when to refer to a specialist center if the diagnosis is suspected, to understand the treatment options available and the evidence-based antenatal care schedule. Okay, so the fetal cardiac conduction system develops at 16 weeks of gestation. A fetal cardiac arrhythmia is defined as a heart rate that's either too fast, that's greater than 200 beats, or too slow, that's less than 100 beats, or has an irregular rhythm. The commonest form of fetal cardiac arrhythmias is atrial extrasystoles, reported in about 14% of healthy babies. Fetal cardiac arrhythmias account for up to 20% of referrals to fetal cardiologists. Congenital heart block is most commonly caused by transplacental passage of anti-Rho and anti-La antibodies. Most fetal tachycardias occur either when there is abnormal, irritable focus of atrial tissue causing persistent rapid impulse propagation, atrial flutter, or because of an abnormality of the AV atrioventricular junction, which allows the ventricular impulse to re-enter the atria, producing a re-entry circuit, atrioventricular re-entry tachycardia. Okay, this then gets us onto a nice green box where we look at imaging modalities used in the assessment of fetal cardiac arrhythmias. So modality is a 2D cardiac imaging and Doppler studies. Application of this is assessment of structural cardiac defects, atrial and ventricular function, chamber sizes, flow velocities at valves. Next modality is M-mode, which helps us to see atrial and ventricular contraction, coordination, sequence and interval of AV contraction. Next modality is extracardic ultrasound imaging, helps us to see assessing the extracardic abnormalities, amniotic fluid volume, umbilical artery, middle cerebral artery, pulsatility indices, and systolic velocities. Fetal electrocardiography, fetal ECG. Invasive fetal ECG methods, also known as ST analysis, STAN, have been used in intrapartum settings to monitor for fetal acidemia. Non-invasive fetal ECG methods, which discern fetal heart rhythms from 17 weeks of gestation with electrodes placed on the maternal abdomen, have recently been used to diagnose fetal arrhythmias. These have the advantage of providing additional information over a longer time period than traditional echocardiography, but there remains concerns about this technique's ability to discern fetal atrial activity, and presently this technique is limited to research settings. Another modality is fetal magnetocardiography, FMCG. Fetal magnetocardiograms are another technology present limited to research settings. The trace is acquired using biomagnetometers, and recordings must be performed in a magnetically shielded room. FMCG has been used to as an adjunct to traditional echocardiography in the diagnosis of fetal arrhythmias and structural defects. Okay, this then gets us on to another green table, transplacental therapy for fetal tachyarrhythmias. So, this table talks about different drugs, therapeutic maternal dose range, therapeutic level and effect, and toxicity. The first drug is digoxin. The loading dose is 1200 and 1500 micrograms in 24 hours IV, divided every 8 hours. Maintenance dose 375 to 750 micrograms daily, divided every 8 to 12 hours post-operatively. Therapeutic effect level is 0.7 to 2.0 micrograms per milliliters. An effect is nausea, fatigue, loss of appetite, sinus bradycardia, first degree AV block, rare nocturnal VENCUBAC AV block. Toxicity is nausea, vomiting, plus sinus bradyarrhythmias or AV block, proarrhythmias. The next drug is flecainide, 100 to 300 milligrams daily, divided every 8 to 12 hours post-operatively. 0.2 to 1.0 micrograms per milliliter is the therapeutic level. Mild P and QRS widening, first degree AV block, QTC interval less than 0.48 seconds, and headaches. Toxicity is, some symptoms are visual and central nervous system symptoms, bundle branch block, QTC interval of more than 0.48 seconds, maternal and fetal proarrhythmias. The next drug is sotalol, 160 to 480 milligrams daily, divided every 8 to 12 hours post-operatively. Levels not monitored. Bradycardia, first degree AV block, P and QRS widening, QTC less than 0.48 seconds. Toxicity symptoms include nausea, vomiting, dizziness, QTC greater than 0.48 seconds, fatigue, bundle branch blocks, maternal and fetal proarrhythmias. Okay, so this then leads us on to the next flowchart, which talks about sustained SVT and atrial flutters, fetal heart rate greater than 180 in a singleton pregnancy that's over 17 weeks and is less than 37 weeks. Then it goes on to saying if it's atrial flutter and is hydropic, the first line is flecainide, second line is flecainide and digoxin, and third line is digoxin and sotalol. If it's atrial flutter but it's non-hydropic, then the first line is digoxin, second line is digoxin and flecainide, and third line is digoxin and sotalol. If it's SVT in a hydropic or non-hydropic baby, first line is flecainide, second line is flecainide and digoxin, and third line is digoxin and sotalol. Okay, we then move on to the next flowchart, which talks about bradycardia, so fetal heart rate consistently below 100 beats per minute, acute causes and fetal hemodynamic compromise. If that's a yes, consider urgent early delivery. If that's a no, then urgent fetal cardiology referral. Evaluate fetal heart rhythm and cardiac structure. Normal structure and evidence of heart block. If anti-Ro and LAR antibodies, consider transplacental therapy. If it's normal structure and evidence of heart block, the heart rate is less than 60 with high drops, decreased fetal movements, consider early delivery / balance risks of prematurity. If normal structure and evidence of heart block with heart rate of greater than 60 with no high drops, then consider early term delivery. I think this is quite important. So in a patient who has anti-Ro and anti-LAR antibodies and has had a previous pregnancy that was affected by fetal heart block, starting these patients on hydroxychloroquine before 10 weeks of gestation can try and minimize reoccurrence. At 18 weeks of gestation, a fetal echo is advised, and fetal heart is monitored with a handheld Doppler at midwifery led appointments every 2 weeks from 20 weeks. Okay, so the next article is oophorectomy or ovarian conservation at the time of hysterectomy for benign disease. So key content is bilateral salpingo-oophorectomy is indicated for patients with suspected or confirmed gynecological malignancy. Risk reduction surgery is indicated in patients with a significant family history or a genetic predisposition to developing breast or ovarian cancer. Bilateral salpingectomy with ovarian conservation reduces the risk of ovarian cancer whilst preserving ovarian function. Oophorectomy prior to the menopause associated with increased all-cause mortality and significant menopause-related morbidity. Conservative measures such as weight loss, family planning, and lifestyle advice could reduce the overall lifetime risk of ovarian cancer. Learning objectives is to understand the rationale of the decision-making process for bilateral salpingo-oophorectomy or bilateral salpingectomy with the ovarian conservation time of hysterectomy for benign disease. To understand the risk-benefit balance of performing oophorectomy in the context of risk reduction of high-risk patients, compared with patients with no genetic predisposition or family history, to consider conservative risk reduction measures that do not involve oophorectomy. Okay, the article then goes on to talk about ovarian cancer. Lifetime risk of developing ovarian cancer in the population is 1.4%. Risk of ovarian cancer in patients with hereditary ovarian cancer syndromes may be as high as 25 to 50% for epithelial ovarian cancers. BRCA mutations account for nearly 90% of hereditary ovarian cancers, but make up of only about 10 to 15% of overall ovarian cancers. Diagnosis of ovarian cancer at the age of 70 years associated with 80% mortality. Evidence of ovarian cancer is 10 in 100,000 in the 40s, incidence. It increases up to 50 in 100,000 in the over 80s. So I just go through over again. So incidence of ovarian cancer in the 40s is 10 in 100,000, goes up to 50 in 100,000 in those over the age of 80. Benefit of risk reduction surgery of bilateral salpinge oophorectomy with somebody with BRCA gene carriers, Lynch syndrome, and Peutz-Jeghers syndrome. Non-hereditary risk factors include obesity and polycystic ovarian syndrome. Ovarian endometriosis can transform to malignancy in 2.5%. Okay, there is continuing production of androgens such as androstenedione and testosterone in patients who are postmenopausal, which then undergo aromatase conversion to estrone in adipose tissues. Estrone is then converted to estradiol peripherally in the adipose tissues. So even in patients who are postmenopausal, there is still some function of the ovary in terms of producing the androgens, which are then eventually converted to estradiol peripherally in the adipose tissues. So bilateral oophorectomy in somebody who's less than 45 years of age is associated with increased cardiovascular mortality by 1.5 times. Decline of ovarian sex steroid hormones leads to low estrogen and testosterone levels, which can cause bone loss, osteopenia. Low bone mass in the menopause causes fractures and a susceptibility to cancer metastases in the bones. It also reduces sexual pleasure because of the decrease in the sex steroid hormones. When oophorectomy is performed in premenopausal women, the cognitive decline starts at that point and progresses. Vasomotor symptoms are more abrupt and severe onset of surgical menopause. There's two groups of ovarian cancers, type 1 and type 2. Type 1 are the low-grade indolent tumours, low-grade serous, low-grade endometrioid, clear cell, mucinous and transitional Brenner carcinomas. Type 2 are aggressive epithelial tumours, including high-grade serous carcinomas, undifferentiated carcinomas, and carcinoma. The distant fallopian tube appears to be the origin for serous ovarian cancers, particularly with BRCA gene mutations. Type 2 tumours display the type p53 mutations. The risk of ovarian cancer is reduced by 20% for every 5 years, and is halved in women who are taking long-term hormonal contraception for 15 years. Pregnancy and breastfeeding for longer than 12 months also reduces the risk of ovarian cancer. Hysterectomy with ovarian conservation also reduces the risk of ovarian cancer by 34%. Tubal ligation alone reduces the risk of ovarian cancer by 34%. The Royal College of Obstetricians and Gynecologists, the RCOG, recommends bilateral salpingectomy with ovarian conservation at hysterectomy. Okay, so the next two green boxes. So the first one is considerations for ovarian preservation. Consider bilateral salpingectomy with ovarian preservation in patients who are premenopausal without genetic predisposition to cancer, have no significant family history of ovarian cancer, have no head and neck pelvic pathology, are postmenopausal women with no additional risk factors. Indications for bilateral salpingo oophorectomy, suspected or confirmed gynecological malignancy, risk reduction surgeries like, for example, in somebody who's BRCA1, BRCA2, Lynch syndrome, Peutz-Jeghers syndrome, and a strong family history of ovarian cancers only after completion of childbearing and over the age of 35. Other indications like chronic pelvic pain, PID, or severe endometriosis. Okay, the last article is titled as Paraneoplastic Syndrome Associated with Gynecological Malignancy, a review of the evidence. Key content. Paraneoplastic syndromes is a clinical manifestation of both the benign and malignant tumours. Symptoms are not attributable to direct organ involvement of the cancer, nor as a therapeutic adverse effect. Instead, they are a result of hormones, cytokines, or growth factors released by the tumour or an immunological response. Paraneoplastic syndromes can affect any body systems, so it can cause myriad potential symptoms. These clinical manifestations predate those of the underlying disease process. The incidence of the paraneoplastic syndromes attributable to gynecological tumours is increasing, resulting in considerable morbidity in those affected. There is an overall lack of awareness of PNS among clinical clinicians. This, combined with wide-ranging of symptoms, creates an opportunity for diagnostic difficulty and therapeutic delay. Learning objectives: to raise awareness among clinicians, to aid earlier diagnosis and treatment of paraneoplastic syndromes. So, paraneoplastic syndromes is a clinical manifestation of a tumor process, not from direct organ involvement, metastatic disease, or an adverse effect of treatment. Incidence in all oncology patients is about 8%. In the UK, more than 21,000 women are diagnosed with a gynecological malignancy every year. Okay, so next table is about the paraneoplastic syndromes and the commonest underlying malignancy. Cushing's syndrome, neuroendocrine carcinomas, hypothyroidism, gestational trophoblastic disease, and stroma ovariae. Hypercalcemia, advanced malignancy of any origin, although it's not a true paraneoplastic syndrome, small cell carcinoma of the ovary. Hyperglycemia, ovarian stromal carcinoid, paraneoplastic cerebellar degeneration, ovarian and endometrial carcinomas, paraneoplastic encephalitis, which can be neuronal nuclear or neuronal surface. So the ovarian carcinoma is neuronal nuclear, and the neuronal surface is ovarian teratomas. And then dermatomyositis, which is seen in ovarian cancers. Okay, so on this slide we have two green boxes. This is the last slide for this presentation. Thank you for sticking around and getting this far. So the first box is the FIGO scoring system for gestational trophoblastic disease by prognostic factor. So the parameters are age, previous pregnancy, months since last pregnancy, pre-treatment HCG levels, number of metastases, site of metastases, large tumour mass, previous chemotherapy. The FIGO stage of 0, 1, 2, and 4, 0, 1, 2, and 4, there's no 3. Total score of less than 6 is equal to low risk of resistance to treatment. Total score of more than or equal to 7 is high risk of resistant treatment. Okay, the next green box is the FIGO anatomical staging of gestational trophoblastic neoplasm. Stage 1 is disease confined to the uterus. Stage 2 is gestational neoplasia extends outside of the uterus but is limited to genital structures including adnexia, vagina, broad ligament. Stage 3 is gestational trophoblastic neoplasia extends into the lungs with or without known genital tract involvement, and stage 4 is all of the metastatic sites. Thank you so much for listening. I really hope this is useful for you. As I said, it's been a great help for me to be able to summarize these slides for my revision when I was studying for the Part 2 exam. And because it's helped me, I want to share it with you, so you can also take the maximum benefit out of this. Please share, comment, and let me know if there's any changes that you want to see within the presentation of these slides. If you don't want me to go through the green boxes and so forth. I want this process to be useful to you, and I will be sharing more TOG summaries for the upcoming exam. So please subscribe to my channel and hit the like button if you have enjoyed watching today.